Hello, my name is Azzy Brown. This presentation focuses on sepsis, including its pathophysiology, clinical progression, and nursing care. This is for Nursing 303, Nursing Pathophysiology, at Trinity College of Nursing and Health Sciences under Professor Campbell for spring 2026. I am a second-year BSNB nursing student at Trinity College of Nursing and Health Sciences in Rock Island, Illinois. In this presentation, I will be discussing sepsis and its impact on patient outcomes and nursing care. By the end of this presentation, the learner will be able to define sepsis and describe its pathophysiology. They will also be able to identify common clinical manifestations and diagnostic findings associated with sepsis. In addition, this presentation will outline priority nursing assessments and interventions for patients with sepsis. Further objectives include discussing medical management and pharmacological treatments, recognizing potential complications, and identifying key patient education priorities. Sepsis is caused by an infection from bacteria, viruses, fungi, or parasites. It typically begins as a localized infection, such as pneumonia or a urinary tract infection, and then spreads into the bloodstream. As the infection progresses, it triggers a systemic inflammatory response throughout the body, which can lead to widespread tissue damage and organ dysfunction. Ultimately, sepsis represents a body-wide infection that overwhelms the immune system and can result in severe multi-organ compromise. As we just mentioned, sepsis begins as a localized infection, such as one in the lungs, urinary tract, or abdomen. As the infection progresses, it can spread into the bloodstream and become systemic. At this point, the body's immune response becomes dysregulated, meaning it is no longer protective and instead contributes to widespread inflammation and tissue injury. This affects multiple organ systems throughout the body. Sepsis exists on a continuum that can progress from sepsis to septic shock and ultimately to organ failure if not treated quickly. Because of this rapid progression, sepsis is considered a medical emergency that requires immediate recognition and intervention. Several factors increase a patient's risk for developing sepsis. These include extremes of age, such as patients over 65 years old or infants, as well as individuals with chronic illnesses like diabetes, chronic kidney disease, COPD, or cancer. Patients who are immunocompromised, including those receiving chemotherapy, living with HIV, or taking long-term steroids, are also at higher risk. In addition, the presence of invasive devices such as urinary catheters, central lines, or mechanical ventilation can increase infection risk. Recent surgery, trauma, or burn injuries further elevate the likelihood of developing sepsis due to disruption of normal protective barriers. The progression of sepsis begins with a localized infection like we talked about earlier, such as a urinary tract infection, pneumonia, or a wound infection. If the infection triggers a systemic inflammatory response, the patient develops systemic inflammatory response syndrome, or SIRS. This is characterized by signs such as fever, tachycardia, tachypnea, or abnormal white blood cell counts. When SIRS occurs in the presence of a confirmed or suspected infection, the condition is defined as sepsis. At this stage, early organ dysfunction may begin to develop. If sepsis worsens and significant organ dysfunction occurs, it progresses to severe sepsis, affecting organs such as the kidneys, liver, lungs, or heart. Further deterioration can lead to septic shock, which is characterized by persistent hypotension despite fluid resuscitation and carries a high risk of multi-organ failure. The final stage is multiple organ dysfunction syndrome, or MODS, where two or more organ systems fail, which is often fatal if not treated aggressively. In sepsis, the immune system becomes overactivated in response to infection, which leads to widespread inflammation throughout the body rather than a localized response. This causes vasodilation, where blood vessels relax, and capillary leak, where fluid shifts out of the bloodstream into surrounding tissues. Together, this results in hypotension and decreased tissue perfusion. As the process continues, microvascular thrombosis can develop, meaning small clots form within the tiny blood vessels. This further restricts oxygen delivery to tissues and leads to organ ischemia and dysfunction. At the same time, a cytokine storm occurs, which is an excessive release of inflammatory mediators that amplifies tissue damage and systemic instability. As perfusion to tissues decreases, oxygen delivery becomes insufficient, leading to cellular hypoxia. In response, cells shift to anaerobic metabolism, which results in the production of lactic acid and lactic acidosis. Endothelial damage also occurs, increasing vascular permeability and causing fluid to leak into tissues, which contributes to edema and further reduces effective circulation. As these processes continue, major organs such as the kidneys, lungs, and heart begin to lose function. If hypotension persists despite treatment, the patient progresses into septic shock, Without rapid intervention, this can ultimately lead to multiple organ dysfunction syndrome, where multiple organ systems begin to fail simultaneously. In the later stages of sepsis, the immune system becomes both overactive and suppressed at the same time, creating a dysregulated response. This imbalance leads to mitochondrial dysfunction, which reduces the cell's ability to produce energy in the form of ATP, resulting in cellular energy failure. Coagulation abnormalities can also develop, increasing the risk for disseminated intravascular coagulation and widespread microvascular injury. Metabolic changes such as hyperglycemia and increased energy demand place additional stress on the body. Over time, the immune system becomes exhausted, making the patient more vulnerable to secondary infections. This combination of factors leads to progressive organ failure and significantly increases mortality risk if not treated promptly. Sepsis should be suspected when a patient begins showing early signs of deterioration, particularly changes in mental status, such as confusion or decreased alertness. Hypoxemia, or low oxygen levels, is also a key warning sign that tissue oxygenation is becoming impaired. Laboratory findings such as elevated plasma lactate levels may indicate poor tissue perfusion and the onset of anaerobic metabolism. Sepsis can also present with signs of impaired organ function or reduced tissue perfusion. This may include a low systolic blood pressure, typically less than 100 millimeters of mercury, or decreased urine output, known as oliguria, which reflects declining kidney perfusion and function. Sepsis most significantly affects three major body systems due to widespread inflammation and impaired perfusion. The cardiovascular system is primarily impacted, leading to hypotension, decreased tissue perfusion, and the potential for shock. The renal system is also commonly affected, resulting in acute kidney injury and decreased urine output, or oliguria, due to reduced renal blood flow. Finally, the respiratory system is involved, where impaired gas exchange can lead to acute respiratory distress syndrome, or ARDS, and hypoxemia. In sepsis, the cardiovascular system is significantly affected due to systemic inflammation and vascular dysfunction. Vasodilation and capillary leak cause a drop in vascular tone and fluid loss from the intravascular space, which leads to hypotension and decreased blood pressure. As a compensatory response, the heart rate increases, resulting in tachycardia in an attempt to maintain adequate tissue perfusion. Despite this compensation, overall perfusion to vital organs continues to decrease, increasing the risk for shock and progression to multi-organ dysfunction. In addition, microvascular thrombosis can occur, leading to tissue ischemia at the cellular level. Sepsis also causes a decrease in systemic vascular resistance, which further impairs circulation and blood flow. Over time, myocardial depression may develop, reducing cardiac output and worsening overall tissue perfusion. In sepsis, the renal system is highly vulnerable due to decreased perfusion and reduced blood flow to the kidneys. This reduction in oxygen delivery impairs normal kidney function. As a result, acute kidney injury can develop, which leads to impaired filtration and decreased ability to remove waste products from the blood. One of the earliest clinical signs is oliguria, defined as urine output of less than 30 milliliters per hour. As kidney function declines, electrolyte imbalances may occur, increasing the risk for serious complications such as dysrhythmias. Fluid retention can also develop due to the kidney's inability to properly regulate fluid balance, leading to edema and accumulation of waste products. If this continues, metabolic acidosis can occur as the kidneys are no longer able to effectively excrete acids, resulting in a decreased blood pH. In sepsis, the respiratory system is affected due to a widespread inflammatory response within the lungs, which impairs normal gas exchange. Increased capillary permeability allows fluid to leak into the alveoli, leading to pulmonary edema. This fluid accumulation further disrupts oxygen exchange and reduces lung compliance. As the condition progresses, acute respiratory distress syndrome, or ARDS, can develop, which is characterized by severe hypoxemia, which is often difficult to correct. Patients may also exhibit tachypnea and signs of respiratory distress as the body attempts to compensate for low oxygen levels. In addition, ventilation perfusion mismatch occurs, meaning airflow and blood flow in the lungs are not properly aligned, which further reduces oxygenation. In severe cases, alveolar collapse or atelectasis can develop, significantly worsening gas exchange and contributing to respiratory failure. In sepsis, patients present with a wide range of clinical signs and symptoms related to systemic infection and impaired perfusion. Common early findings include fever or hypothermia, along with tachycardia and hypotension as the cardiovascular system becomes compromised. Patients may also develop tachypnea and shortness of breath due to respiratory involvement. Neurologically, altered mental status is common and may present as confusion, agitation, or decreased alertness. Renal impairment is reflected by decreased urine output or oliguria. Patients may also exhibit cool, clammy, or sometimes flushed skin due to poor peripheral perfusion. Metabolic changes can include elevated blood glucose levels, even in patients without a history of diabetes. Overall, patients often appear weak, fatigued, and generally unwell as the infection progresses systemically. In this mnemonic, the signs of sepsis are highlighted in an easy-to-remember format. S stands for shivering, fever, or feeling very cold. E represents extreme pain or general discomfort. P refers to pale, clammy, or sweaty skin. S indicates sleepy, difficult to arouse, or confused mental status. I represents feeling of impending doom, or the sense that something is seriously wrong. And the final S stands for shortness of breath, which reflects respiratory compromise. Sepsis is diagnosed based on a combination of clinical assessment and laboratory findings, as there is no single test that can definitively confirm it. Diagnosis is typically suspected when there is a known or suspected infection, along with signs of organ dysfunction. Clinicians may also use screening tools such as the Q-SOFA or SOFA scoring systems to help identify patients at risk. Key clinical indicators include hypotension, altered mental status, and elevated lactate levels, which suggest impaired tissue perfusion. Supporting laboratory tests include blood cultures to identify the causative organism, a complete blood count to assess white blood cell response, lactate levels to evaluate oxygen delivery, and additional tests of organ function. Because sepsis can progress rapidly, diagnosis relies heavily on early recognition, clinical judgment, and immediate initiation of treatment. Priority laboratory findings in sepsis are essential for confirming infection, assessing severity, and identifying early organ dysfunction. These labs help guide clinical decision-making and allow for rapid recognition of deterioration. The most important initial laboratory findings include blood cultures, complete blood count, and serum lactate levels, which together provide key information about infection status, immune response, and tissue perfusion. In sepsis, blood cultures are used to identify the causative organism present in the bloodstream. Positive cultures confirm the presence of infection and help guide targeted antibiotic therapy, which is essential for effective treatment. Normally, blood cultures show no growth. A red flag finding is any detection of bacterial or fungal growth, which indicates active bloodstream infection. From a nursing perspective, it is important to ensure proper aseptic technique during blood collection to avoid contamination of the sample. Nurses should also monitor the puncture site for signs of infection and ensure timely collection prior to the initiation of antibiotics whenever possible. In sepsis, a complete blood count, or CBC, is used to evaluate the body's hematologic response to infection by assessing white blood cells, red blood cells, and platelets. Changes in white blood cell count are particularly important. An elevated WBC, or leukocytosis, indicates an active immune response to infection, while a low WBC, or leukopenia, may suggest severe infection or immune system suppression. Platelet abnormalities are also significant, as decreases can increase the risk for bleeding, while changes may also indicate clotting dysfunction. Normal white blood cell values range from 4,000 to 11,000, and normal platelet values range from 150,000 to 400,000. Abnormal findings include white blood cell levels below 4,000 or above 12,000, and platelet counts below 150,000 or above 400,000. From a nursing standpoint, patients should be monitored closely for signs of infection, bleeding, or bruising, and abnormal lab results should be promptly reported to the provider. In sepsis, lactate levels are used to measure tissue hypoperfusion and assess the severity of illness. An elevated lactate level indicates inadequate oxygen delivery to tissues and a shift towards anaerobic metabolism. This is a key marker used to identify severe sepsis and septic shock. Normal serum lactate levels range from 0.5 to 2.2. A level greater than 2 is concerning for sepsis, while levels greater than 4 are associated with a high risk for septic shock and organ failure. From a nursing perspective, vital signs and overall tissue perfusion should be closely monitored. Lactate levels are often repeated as ordered to evaluate the patient's response to treatment and improvement in perfusion. In addition to laboratory testing, several diagnostic studies are used to identify the source of infection and evaluate the severity of sepsis. Imaging studies such as a chest X-ray or CT scan can help identify the underlying infection source. Pulse oximetry is used to assess oxygenation status and detect early respiratory compromise. A sputum culture may be obtained to evaluate for respiratory infections, while urinalysis helps identify a urinary source of infection. If central nervous system infection is suspected, a lumbar puncture may be performed. Arterial blood gases are used to assess oxygenation and acid-base balance, and coagulation studies are important for identifying clotting abnormalities and potential development of disseminated intravascular coagulation. In cardiovascular assessment for a patient with sepsis, the nurse closely monitors blood pressure, heart rate, and mean arterial pressure, along with capillary refill, skin temperature, extremity color, peripheral pulses, and overall tissue perfusion. Expected abnormal findings include hypotension, often defined as a systolic blood pressure below 100 millimeters of mercury, or a mean arterial pressure below 65 millimeters of mercury. Tachycardia is commonly present as a compensatory response to maintain cardiac output. Patients may also present with cool, clammy, and pale extremities due to decreased perfusion along with weak or thready pulses. Unexpected findings can include a normal blood pressure despite the presence of infection, which may suggest early compensated sepsis. Alternatively, warm flush skin with bounding pulses may indicate the early vasodilatory phase of septic shock. Nursing interventions include administering IV fluids and vasopressors as prescribed, closely monitoring hemodynamic status, and promptly reporting any persistent hypotension or changes in perfusion. In renal assessment for sepsis, the nurse monitors urine output on an hourly basis when possible, along with strict intake and output measurements. Serum creatinine and blood urea nitrogen levels are also evaluated to assess kidney function. Expected abnormal findings include oliguria, defined as urine output less than 30 milliliters per hour, along with elevated creatinine and BUN levels. Urine may also appear dark and concentrated due to decreased renal perfusion. Unexpected findings may include normal urine output despite systemic infection, which could indicate an early stage of sepsis before renal involvement becomes apparent. Sudden anuria, or complete absence of urine output, may indicate severe acute kidney injury. Nursing interventions include maintaining strict intake and output monitoring, administering IV fluids as ordered to support perfusion, and promptly reporting decreased urine output or rising creatinine levels to the provider. In respiratory assessment for sepsis, the nurse monitors respiratory rate, oxygen saturation, and work of breathing. Lung sounds are assessed for any abnormal findings, and arterial blood gases may be evaluated if available. Expected abnormal findings include tachypnea, decreased oxygen saturation indicating hypoxemia, crackles or diminished breath sounds, and increased work of breathing, often demonstrated by use of accessory muscles. Unexpected findings may include normal oxygen saturation despite the presence of sepsis, which can occur in early or compensated stages. A sudden respiratory decline may indicate progression to acute respiratory distress syndrome or respiratory failure. Nursing interventions include administering supplemental oxygen as ordered, positioning the patient to optimize breathing, such as in high Fowler's position, and closely monitoring for signs of respiratory distress while promptly notifying the provider of any deterioration. In cardiovascular management of sepsis, the primary interventions focus on restoring and maintaining adequate perfusion. IV fluid resuscitation with crystalloids is used first to increase circulating volume and improve tissue perfusion. If hypotension persists despite fluid administration, vasopressors such as norepinephrine may be initiated to constrict blood vessels and raise blood pressure. Continuous hemodynamic monitoring, including blood pressure and mean arterial pressure, is essential to evaluate response to treatment and ensure adequate tissue perfusion. In more critical cases, central line monitoring may be required for more accurate assessment and medication administration. Expected outcomes of cardiovascular medical management in sepsis include maintaining a mean arterial pressure of at least 65 millimeters of mercury consistently, along with adequate peripheral perfusion demonstrated by warm extremities and capillary refill of less than 3 seconds. Additional expected outcomes include a normal or improving heart rate as the patient stabilizes, and overall hemodynamic stability without the need for frequent escalation of vasopressor support. Clinically, this is reflected by resolution of hypotensive episodes and a reduction in signs of shock, such as improved mental status and better skin color, indicating improved systemic perfusion. In renal medical management of sepsis, interventions focus on restoring kidney perfusion and supporting renal function. IV fluid resuscitation is used to improve blood flow to the kidneys and support adequate filtration. Electrolyte management is also essential, as imbalances can significantly affect cellular and cardiac function, especially in critically ill patients. In cases of severe kidney failure, renal replacement therapy, such as dialysis, may be required to assist with waste removal and maintain fluid and electrolyte balance. Expected outcomes of renal medical management in sepsis include maintaining urine output at or above 30 milliliters per hour, indicating adequate kidney perfusion and function. Additional expected outcomes include stable or improving creatinine and blood urea nitrogen levels, as well as balanced electrolytes such as sodium and potassium within normal ranges. Clinically, patients should show no signs of fluid overload, resolution of oliguria or anuria, and ideally avoidance of acute kidney injury progression or the need for renal replacement therapy such as dialysis. In respiratory medical management of sepsis, interventions focus on improving oxygenation and supporting adequate gas exchange. Supplemental oxygen therapy is used to increase oxygen delivery to tissues and correct hypoxemia. If respiratory failure or acute respiratory distress syndrome develops, mechanical ventilation may be required to support adequate ventilation and oxygenation. Positioning the patient, such as placing them in high Fowler's position, helps improve lung expansion and enhances overall oxygen delivery. Expected outcomes of respiratory medical management in sepsis include maintaining oxygen saturation at or above 92% or at the patient's baseline, along with normal or improving arterial blood gas values, including partial arterial pressure of oxygen and partial arterial pressure of carbon dioxide. Additional outcomes include a reduction in work of breathing, indicating improved respiratory efficiency and gas exchange. Clinically, patients should show absence of respiratory distress, such as tachypnea or use of accessory muscles, prevention of progression to acute respiratory distress syndrome, and adequate oxygen delivery to tissues as reflected by overall clinical improvement. For this slide, the Sepsis 6 bundle outlines a set of evidence-based interventions that should be initiated promptly once sepsis is suspected. These include administering oxygen, obtaining blood cultures, giving IV antibiotics, starting IV fluids, measuring lactate levels, and monitoring urine output. The goal of this bundle is rapid recognition and immediate treatment to reduce progression to septic shock and improve patient outcomes. This slide summarizes the stepwise medical management approach to sepsis based on the patient's perfusion status and response to therapy. If perfusion is adequate, ongoing monitoring is continued to ensure stability. If perfusion is inadequate, a fluid challenge is initiated to assess response and improve circulating volume. If hypotension or poor perfusion persists despite fluids, a norepinephrine challenge may be started to support blood pressure through vasoconstriction. If cardiac output remains insufficient, an inotrope challenge may be used to improve cardiac contractibility and perfusion. As the patient stabilizes, a vasopressor reduction challenge is considered to gradually wean medications while ensuring that perfusion and blood pressure remain stable throughout the recovery process. Norepinephrine, also known as Levophed, is a vasopressor commonly used in the management of septic shock. It is administered as a continuous IV infusion, typically starting around 8 to 12 micrograms per minute, and is titrated based on the patient's mean arterial pressure. Its mechanism of action involves stimulation of alpha adrenergic receptors, which causes vasoconstriction. This increases systemic vascular resistance, thereby raising blood pressure and improving tissue perfusion in patients with sepsis-induced hypotension. Norepinephrine can cause several important adverse effects, including hypertension, reflex bradycardia, and peripheral ischemia due to excessive vasoconstriction. From a nursing standpoint, it is essential to closely monitor blood pressure and mean arterial pressure, along with overall tissue perfusion, to ensure the medication is achieving the desired effect without causing harm. The IV site should be assessed frequently for signs of extravasation, since infiltration can lead to tissue injury. The infusion is titrated according to provider orders to maintain a mean arterial pressure of at least 65 millimeters of mercury. Zosyn is a broad-spectrum antibiotic commonly used in the treatment of sepsis. It is administered intravenously in doses ranging from 3.375 to 4.5 grams every 6 to 8 hours, with adjustments made based on renal function. Its mechanism of action involves inhibition of bacterial cell wall synthesis, which leads to bacterial cell death. The addition of tazobactam inhibits beta-lactamase enzymes, helping to prevent bacterial resistance and broaden antimicrobial coverage. Zosyn can cause several important adverse effects, including allergic reactions ranging from mild rash to severe anaphylaxis. Gastrointestinal effects such as diarrhea may also occur, including the risk of C. difficile infection. In addition, electrolyte disturbances, such as changes in sodium and potassium levels, may develop during therapy. From a nursing perspective, it is important to closely monitor the patient for signs of allergic reaction, especially during initial dosing. Renal function should be assessed before and throughout treatment to ensure appropriate dosing and prevent toxicity. The nurse should also monitor for diarrhea or signs of secondary infection and report concerning findings promptly. Hydrocortisone is a corticosteroid that may be used in sepsis, particularly in cases of septic shock that are not responsive to fluids and vasopressors alone. It is typically administered intravenously at a total daily dose of around 200 milligrams, either in divided doses or as a continuous infusion, depending on provider protocol. Its mechanism of action involves reducing systemic inflammation and helping stabilize blood pressure by improving the body's response to vasopressors, which can support hemodynamic stability in septic shock. Hydrocortisone use in sepsis can lead to several important side effects, including hyperglycemia, immunosuppression, which increases the risk of secondary infections, and fluid retention that may contribute to hypertension. From a nursing perspective, blood glucose levels should be closely monitored due to the risk of steroid-induced hyperglycemia. The patient should also be observed for any signs of new or worsening infection. In addition, blood pressure and overall fluid status should be assessed regularly to identify fluid retention and maintain hemodynamic stability. In the nursing priorities and plan of care for sepsis, the first priority is maintaining hemodynamic stability. Interventions include administering IV fluids, closely monitoring vital signs, and titrating vasopressors per protocol. These actions work together to restore adequate tissue perfusion and improve oxygen delivery to vital organs. The expected outcomes are maintaining a mean arterial pressure of 65 millimeters of mercury or greater, improved tissue perfusion, and stabilization of heart rate and blood pressure. In the nursing priorities and plan of care for sepsis, the next nursing priority is rapid infection control and elimination of the source. Interventions include administering antibiotics promptly, monitoring culture results, and maintaining strict infection control practices. These actions help eliminate the infection source and reduce progression to septic shock. Expected outcomes include normalization of white blood cell count, absence of fever, and resolution of infection-related signs and symptoms. Another nursing priority in the plan of care of sepsis is early detection of organ dysfunction and providing supportive care to prevent progression to multi-organ failure. Interventions include monitoring urine output, respiratory status, and laboratory values, as well as providing oxygen therapy and renal support as needed. These interventions allow for early recognition of deterioration and timely support of affected organ systems. Expected outcomes include adequate urine output, oxygen saturation of 92% or greater, and stabilization of laboratory values such as creatinine, lactate, and electrolytes. The first potential complication of sepsis is septic shock. As we talked about earlier, this is a severe progression of sepsis in which widespread vasodilation and capillary leak lead to persistent hypotension and inadequate tissue perfusion, even after fluid resuscitation. As a result, oxygen delivery to vital organs is significantly impaired, increasing the risk of multi-organ failure. Early assessment findings include hypotension with a MAP of less than 65 millimeters of mercury, tachycardia, warm flushed skin, mild confusion or restlessness, low-grade fever, and a mild increase in respiratory rate. As the condition worsens, late findings include cold, clammy skin, fluid refractory hypotension, oliguria or anuria, worsening mental status, respiratory distress, and evidence of multi-organ dysfunction involving the kidneys, liver, and the cardiovascular system. Nursing care focuses on rapid stabilization and prevention of further decline. This includes administering IV fluids and vasopressors as ordered, closely monitoring hemodynamic status and urine output, maintaining strict infection control, and promptly reporting any signs of deterioration. The second potential complication of sepsis is acute respiratory distress syndrome, or ARDS. As we now know, this occurs when severe inflammation causes increased permeability in the lungs, leading to fluid accumulation and impaired gas exchange. Early assessment findings include tachypnea, mild dyspnea, restlessness or anxiety, slightly decreased oxygen saturation, fine crackles, and increased work of breathing. As ARDS progresses, late findings include severe dyspnea with hypoxemia that does not improve with oxygen therapy, diffuse crackles or wheezing, use of accessory muscles, cyanosis, decreased lung compliance, and respiratory failure requiring mechanical ventilation. Nursing interventions focus on supporting oxygenation and preventing respiratory failure. This includes providing oxygen or mechanical ventilation as ordered, monitoring respiratory status in ABGs, optimizing positioning to improve lung expansion, suctioning as needed, collaborating with respiratory therapy, and promptly reporting any decline. The third potential complication of sepsis is acute kidney injury, or AKI. This occurs when decreased renal perfusion leads to impaired kidney function and reduced ability to filter waste. Early assessment findings include oliguria with urine output less than 30 milliliters per hour, slight increases in creatinine or BUN, fluid retention, mild edema, fatigue, and dark urine. As AKI progresses, late findings include anuria or severely decreased urine output, significantly elevated creatinine and BUN, electrolyte imbalances such as hyperkalemia or hyponatremia, fluid overload, hypertension, metabolic acidosis, and possible uremic symptoms. Nursing interventions focus on preserving kidney function and preventing further damage. This includes monitoring urine output and daily weights, assessing renal labs and electrolytes frequently, maintaining fluid balance, administering IV fluids or diuretics as prescribed, collaborating with nephrology, and promptly reporting any worsening renal function. The first patient education priority is infection prevention. This includes teaching proper hand hygiene using soap and water or alcohol-based sanitizer, as well as demonstrating correct wound care and dressing changes. Patients should also be instructed to avoid sick contacts and crowded places during recovery and to properly care for any indwelling lines or catheters if present. These measures help reduce the risk of reinfection, prevent secondary infections, and limit the spread of microorganisms to others. The next patient education priority is medication adherence. Patients should understand the importance of completing the full course of antibiotics, even if they start to feel better. They should also be taught the correct dose, timing, and route of administration, along with how to manage minor side effects and when to contact their provider. It's important to emphasize that medication should never be shared with others. This helps ensure the infection is fully treated, prevents antibiotic resistance, reduces the risk of relapse or worsening sepsis, and supports overall recovery. The next patient education priority is recognizing the early signs of sepsis. Patients and their families should be taught to watch for warning signs such as fever, chills, confusion, rapid breathing, decreased urine output, unusual fatigue, dizziness, or persistent nausea. They should also understand when and how to seek emergency care, especially if symptoms suddenly worsen or multiple signs occur at once. Early recognition allows for rapid intervention, reduces progression to septic shock, and improves survival and recovery outcomes. The final patient education priority is lifestyle and recovery support. Patients should be encouraged to get adequate rest and gradually return to normal activities as tolerated. Maintaining proper hydration and a balanced diet rich in protein and vitamins is important to support healing. Patients should also monitor for ongoing symptoms such as fatigue or swelling and report any concerns. Attending follow-up appointments and completing recommended lab monitoring is essential. These measures support immune function, aid in organ recovery, reduce fatigue and complications, and promote long-term healing after sepsis. In summary, sepsis is a life-threatening systemic response to infection that can rapidly progress to multi-organ dysfunction and septic shock if not treated promptly. Early recognition and timely medical management, especially the use of antibiotics and fluid resuscitation, are critical to improving patient outcomes. Priority nursing care focuses on close monitoring of vital signs, laboratory values, organ function, and the patient's response to interventions. Sepsis can lead to serious complications affecting the cardiovascular, respiratory, and renal systems, making early assessment and intervention essential. Patient education plays a key role in recovery and prevention, including infection prevention, medication adherence, recognizing warning signs, and supporting overall health during recovery. Ultimately, a multidisciplinary approach and adherence to evidence-based guidelines are essential to improve patient safety and survival. Thank you so much for listening. These references reflect current evidence-based nursing and medical literature that support the pathophysiology, assessment, diagnosis, and management of sepsis discussed throughout this presentation. I appreciate your time and attention, and this concludes my presentation.